I think everybody can benefit from a periodic 3-day fast.
What does that mean, periodic? Like once a month?
Like monthly. Yeah, once a month, 3 days, water, or you could potentially use bone broth, but keep it low calorie, very low calorie, basically fasted. I think that also helps to maintain some autophagy, some cell cleaning, helps to give you a little bit of resetting. I think about that also from an evolutionary standpoint. I mean, this is how we were in ancient times. Ancient evolutionary times, we had a feast, killed something, we had a harvest, and we ate it, and then we didn't eat for a little while because it wasn't there anymore. We didn't have refrigeration, we didn't have preservation mechanisms. And so that's how our physiology evolved for hundreds of thousands of years. So I think that trying to get something, at least hearkening back to that is helpful.
All right. Well, welcome to the show again, Dr. Abid Husain.
Thank you, Zora. It's a pleasure to be back.
This is a part 2 because we had such a great discussion on heart disease and testing and all these things. And we talked about why heart disease is the #1 killer and what happens in menopause and how to detect risk a little bit earlier. And then even when everything kind of looks normal. So I encourage everybody to go back and listen to that part 1, please. I'll have that in the show notes. So today I want to take a deeper dive into some cholesterol questions and why we're so focused on this. And I also want to cover some of the recommendations or like hacks out there and hear your perspective on these solutions. Okay?
Yeah.
Ready? All right. Yeah, this is great.
Let's get into it.
I could talk to you for hours. And so, yeah, in that first episode, we also talked about why we need to go beyond just testing cholesterol. But I know there's some people out there who are hyper responders. I find that term interesting. I never heard of that before. So maybe you can explain what is a hyper responder and how are they different from like normal people?
Yeah. There's a population of people out there that we're starting to discover called lean mass hyperresponders. And these are a population of people who, as it describes, usually they have low body fat and they have higher muscle mass. And what that does is it changes the metabolism, and in a positive way for sure. But this particular subgroup of athletes, or it may not necessarily even be athletes, but they usually are, when they go into a ketogenic diet or some sort of a low carb diet, their LDL cholesterol shoots way up. And way up meaning into the 200s, 300s, and then their HDLs as well go up very high, above the 80s and sometimes to the triple digits. And so the question has been, what these types of individuals have significant raises in their cholesterol, is that atherogenic? Is the balance maintained, and why is that happening? And this goes into a theory that talks about the energy. It's the lipid energy model, and it talks about how the LDL cholesterol may be being used as a energy source and how it's in response to the energy demands that the muscle has when these individuals reduce their glucose intake. And so how their body is utilizing the lipids for fat oxidation. And so the argument is that these are highly efficient metabolisms that when they go into a ketogenic diet, they don't need the sugar, they use their fat, and then this is an adaptive response that's actually positive.
Have fat, like you said, they're lean.
They're lean, but it's being made in the liver. And so if there's no stores, then the liver's got to make more to fuel these individuals. And so it shows up in the blood, and then it gets cleared as well. So then the question is, how long is it staying in the bloodstream? Is it staying long enough to create inflammation and then plaque?
So is somebody born a lean mass hyperresponder, or it's because they're training and they become lean and they're going some keto or low carb diet?
We're still trying to figure this out, because the belief is that it can be trained. There is a genetic predisposition, and those that may not train as hard or just go through into a ketogenic diet may be able to get into that physiology. But more we see it in athletes, and I think it can be trained into a physiology, because our physiology changes as we get older. It responds to what we put into it. It responds to how we train it, the exercise load, things like that. So as these people develop more muscle, they become more athletic, it can trigger those genes, and then they become that, because it's a combination of things. Not everybody is a lean mass hyperresponder if you take two people with the same body composition.
Oh, interesting. Yeah. So how do you test? Can you test to see if you're one of these people?
Usually, there's no genetic test. It usually shows up in the lipid markers. So these are people that have a really high LDL and it makes everybody freak out. Their HDLs are equally elevated, or at least they're in the upper range of normal. And they're always being told they've got to be put on cholesterol-lowering medication. But it doesn't make any sense because they're athletes, they're healthy, they have good lifestyles, or they're doing something like a ketogenic diet. And most people that are in a ketogenic diet, they're a little bit more savvy about what they're putting in their body, and they're educated enough to know why they're doing it. So it begs a little bit more resistance to just like the reflexive lowering of your cholesterol.
Okay.
So these kind of patients dig into it and they start to figure out, okay, maybe do I need to take this or do I don't? And so that's why there's a big debate about whether these patients need to have their cholesterol lowered or not. And if you look online, there was a study that took lean mass hyperresponders, changed their diet, and then did CTs before and after. And I think they actually had cholesterol lowering medication on one arm and the other. And even the interpretation of the studies is debated. There's one interpretation that says, well, they actually developed plaque at a faster rate than the normal population. The other interpretation says, no, these people did better. So it's really about how they're spinning the numbers. And so we don't really have a clear-cut answer just yet.
Not yet, but I always suspect I'm a lean mass hyperresponder. Like I saw that and I was like, that's me. These
That's right,
crazy
yeah.
LDLs and HDLs. And I never heard of that until it just popped up one day. And I thought, but I think it's only like 10% of the population or 15. It's not like a lot of people.
No.
Yeah.
No, and usually one of the things that they say is that when they go into a ketogenic diet, their LDLs jump really high. And so even that is not necessarily, we get to a point where you can overload the system with too much cholesterol, too much LDL, and you get what's called lipotoxicity, even in somebody that's well-trained and healthy. So then what is that a person that needs their cholesterol to be reduced? We don't know. I don't think we have enough information just yet.
Yeah. When are we going to get information on it? Because I don't know what to do. I'm not a keto person or anything, but
Yeah.
I've leaned towards lower carb in the past. I know better now, but it's still mind blowing because I remember when I was about 45 years old, when I was experimenting with all different kinds of diets and stuff.
Yeah.
The doctor looked at me. The doctor knows me a while, and he's like, gosh, your cholesterol's really high. It was the first time I heard that. And I was like, what? I've always get A pluses when I go to the doctor.
Yeah.
And he says, it's so high. I have to prescribe you a statin, but it just feels so wrong knowing you. And I'm like, does it look like I'm going to have a heart attack? Am I that profile? He's like, no.
Yeah.
And that's when I started to take a much deeper dive into cholesterol and lipid numbers and what in the
Sure.
world's going on, because it just doesn't make any sense. And you quote, try doing all the right things, but yet.
Yeah.
But then you hear the story of those people who are playing tennis, they have a heart attack, they were running,
Sure.
they were healthy. And you're like, oh gosh, you don't want to be one of those because you didn't pay attention and you just ignored this. So this is why we're taking a deeper dive into some of these things and things that keep evolving, right?
Definitely. One of the things that's interesting about these patients, and I think is part of the understanding of our physiology, is that humans don't function well in extremes, and we don't function well in staying in extremes for a long period of time. So even the lean mass hyperresponders, a simple way to reduce the amount of LDL they're generating is to just introduce a little bit of carbs, up to like 25 grams of carbs, and that brings the LDL down and maintains the HDLs. I'm not against ketogenic diets. I think that they have a purpose. I don't think that being in a long-term ketogenic diet is healthy. So cycling it is a good idea if you're one of those people, or if you are doing it for particular reasons, even medically indicated reasons, then cycling in and out of it may be a better idea. But when you're consistently in ketosis for a long period of time, I think it strains the system in a way that we're not meant to be physiologically.
Yeah, I agree. At any kind of diet, I always think it's like a therapeutic thing, right? There's different diets for different people for different reasons, and that helps you. But I'm wondering, how is being a hyperresponder different than somebody who has familial hypercholesterolemia? And maybe explain what that is too.
Well, the difference is if we're taking the energy model as part of the reason why they're becoming hyperresponders, it's that the body is demanding energy sources. And so it's responding. The liver is responding by trying to deliver it through fat generation, through these lipids and triglycerides that are going to be used for maintaining lipid or membrane integrity and as a fuel source. When you have a familial hypercholesterolemia patient, they are producing it, and it's not because of energy demand. They're producing it from a physiologic mismatch or a mutation in their genes that's creating a large output, and it's not being utilized. So then they get deposits in their skin, they get higher oxidative stress, they get lipotoxicity because there's just too much fuel, too much output, and not enough to burn it off, or not enough of a removal mechanism.
And so those people, even though they may be generally healthy and are exercising, healthy diet, no matter what they're doing, they still have these crazy, I guess, lipid panels. And so those people probably need to take a statin or some other kind of medication.
Yeah. What they do to lower their lipids, it depends on their choice and maybe what's best optimal for their physiology, because there's so many options right now. But yeah, they may need to take some sort of lipid lowering measures because they have a mismatch that's not being regulated. It's not because of energy demand, and it's not because it's being utilized the same way. The lean mass hyperresponder is creating more fuel because their body is demanding it, and they will burn it for the most part. The person with hypercholesterolemia, they're pushing out a lot more, and they may be able to increase their demand, or increase the demand of the muscles. But remember, they've got to have, even a lean mass hyperresponder is a specific genetic genotype that creates that. It's some sort of genetic predisposition, and then the physiology. The familial hypercholesterolemia person that has a genetic predisposition in the other way. So they're not necessarily about burning the fat, they're about producing it and maybe not being able to burn it as well.
Okay. So they're completely, you can have two completely different profiles. And could somebody be a lean mass hyperresponder and have familial hypercholesterolemia? Do people cross over in both?
Probably, but I don't know that we've been able to identify that yet. Because then when you get, it's probably the HDLs and the degree to which the HDLs are elevated that you could see that. I don't know that it's been looked at in that detail, but conceivably, it would be hard to tease those apart.
So I know that people who have the ApoE4 gene also tend to have some, I don't want to say cholesterol problems because there's so much more than that, but where does that fit in?
Well, ApoE4 it's a different management of cholesterol. So ApoE4 is one of those lipoproteins that helps to regulate how we're transferring cholesterol, transferring those lipids. And in particular, it's in the brain tissue. It does have an effect in the peripheral tissue, but it predominantly is in the brain. And what it does is it will transfer lipids across between HDLs and LDLs. And if there's a 4 genotype, it impairs the transfer. And so these lipids stick around longer, get more prone to getting oxidized, and then they will create inflammation.
Yeah, and I've heard all kinds of theories where this is sort of evolutionarily speaking, it was protective and it was a good thing, and then nowadays not so good anymore.
That's right. Yeah, the idea was that these were mechanisms that help to produce inflammation more quickly, and then by doing that, they may heal something in a rapid fashion if there was injury, but then if there's a chronic inflammatory insult, then they will stay on and continue to create inflammation long term, which is not what we want right now, because that we live longer and have more chronic inflammation, and so these things get activated to cause oxidative stress much longer.
Yeah, it's like good intentions, but we don't need you anymore, right?
That's right. That's right. An adaptive response that doesn't serve us anymore.
Yeah, insane. So there's another thing that I learned, and I'm not sure how true this is, that in the past, before we had statins, doctors were treating people who had high cholesterol with thyroid medication or thyroid hormone. Is that true? And how does the thyroid and cholesterol dance together?
Yeah, there was a period when that was being experimented with. When in hyperthyroid patients, it's a similar concept as we were just discussing before with the lean mass hyperresponders, in that they have a higher demand. So the thyroid hormone will increase metabolism, increase burning up or consumption of triglycerides and some of the other lipids. So by doing that, it can potentially lower the cholesterol numbers, but at the cost of the metabolism. At some point, if you drive the thyroid numbers up, it will affect other hormones downstream. It'll affect cortisol. It'll affect how much of it stays in our system. And if the cortisol is not staying in the system, if it's burning off quickly, it's a flattened curve. If the curve gets flattened, if we don't have enough, we don't get the natural circadian rhythms, and that can impair our daily function, our daily sleep. So there's like a cascading effect of using high dose thyroid. And you've got to use it at a significantly elevated dose for it to start impacting cholesterol levels. This is what we see in hyperthyroid patients, that their cholesterol is usually in the lower end or quite low, lower than expected. And then we may have to look and see what their thyroid function is.
Yeah, interesting. But people aren't really using this as a treatment anymore, right?
No, definitely not now. We have so many other options, and we've identified why it doesn't really work. I mean, this predates the use of statins for sure.
Yeah. Okay. So this is why people need to go and see somebody like you who can tease out all of these things. And you're so confused, which is why I've seen you. You're like to say my cardiologist. I like to say my cardiologist. But yeah, you're the one I'm seeing now to help me sort out all of these numbers because you can't make any sense out of it. And even AI, you're like, do you really trust it? And does he know the whole picture and all that? So thank you for helping me sort this out myself. And I'll have a link in the show notes how people can reach out to you too. But we talked a little bit about statins. So let's go down that road too, because it's something that most people are familiar with. They hear this, there's a medication to lower cholesterol. Do we really want to do that? Is this the right tool? Yeah. Are they overused? What are your thoughts on when or when not to use statins?
I do think statins get overused. I think that one of the reasons the studies haven't been as robust is because there wasn't really good screening abilities to look at who's getting treated and when. So I think that they're trying to do large population-based studies, but you can't really use statins in that way. They're not good for primary prevention unless we know that you have plaque. So I think that statins do get overused. They're important in a specific population, and that's the population that we know has high risk for an event or high risk for heart disease progression. Because one of the powers of a statin medication is that it's anti-inflammatory. It's not necessarily that lowering the ApoB is our main goal, although that is really what it's been marketed for. It is a potent anti-inflammatory medication. It affects nitric oxide. It amplifies it significantly, up to 40% of what its normal function would be. Mm-hmm. And you probably don't need high doses to do that. So I think that we're probably overdosing patients with statins, and we're also targeting the wrong population. There's a lot of things. Statins are not perfect, but if you are somebody that has had an event, if you're somebody that has evidence of inflammatory physiology, then this is one of the easiest add-on tools that we can start very quickly to remove the inflammation, potentially prevent an event, and then work on changing the physiology so that we can maybe get you off of the statin in the long run. If you have a genetic predisposition, then that's a different story. Then we have to look at long-term options. Maybe we look at what we use to supplement with the statin as well, because taking a statin diminishes a lot of different vitamins, minerals, and key compounds. And so those important to replenish those if we decide to stay with the statin long term, or we can shift to other medications. So now we have PCSK9 inhibitors. There's other medications that are out there that are similar to statins, but not completely. We still have to see if they have the same physiologic impact. I think they do. I'm talking about bempedoic acid. And then there's ezetimibe, which is a completely different molecule. So we have a lot of options right now. And these are just pharmaceuticals. There's so much that's available in non-pharmaceutical route, which is from supplementation to herbs so there's a lot that we can trial and use depending on the preference of whether they want to use a statin or not. But I think the certain populations, it is a really good necessary tool, and I do think that it gets overutilized.
We know a lot of cardiologists, I guess, are gung-ho on the statins, and they're being maybe overprescribed, overused. Yeah. But why are people anti-statin? What's the problem with it?
Well, first of all, it's a mitochondrial inhibitor on some level. All right. It will, by reducing coenzyme Q10, it will reduce some of the major cofactors that are involved with mitochondrial function. In addition to that, it reduces something called geranyl. There are a host of compounds that are in the same pathway that creates CoQ10 and creates cholesterol. They're called isoprenoids. And those compounds are involved with membrane health, inflammation, how we turn on and off proteins, and it's also involved with how well we bring CoQ10 into our mitochondria. So if we're reducing CoQ10 and reducing geranyl, then that both of those are involved with getting that CoQ10 into the mitochondria. It also impacts on some cellular level magnesium. It reduces vitamin D. And then there's the impact it has on the cholesterol biosynthesis pathways. Not everybody has a reduction in hormones, but some people do have a noticeable change in their testosterone and have difficulty, and they may need supplemental therapy after that. So going on a statin often means a host of supportive supplements and medications. You can take CoQ10 with geranyl. You can take vitamin D. You can take your magnesium, and you may need testosterone therapy. You may need all of those without a statin anyway. So it's not that they are going to be something that you have to take because of the statin, but it's something to keep in mind. Starting that does need supportive therapy.
Yeah, so it sounds like, okay, if you're a great candidate for statin, you need to do it a certain way, and you can offset the damage or side effects with other things. And this is why people see you and to do these things. And you mentioned PCSK9 inhibitors. And is that something you'd add on to a statin, or is that instead of a statin, or what is it?
It can be either. Well, it depends on the situation and how low we need to lower the ApoB, because the ApoB is what we're focusing on here. The cholesterol itself is a poor marker for cardiovascular health. ApoB is a much better marker for cardiovascular risk. And so what we want to do is, because that's the number of particles, that's the number of times a cholesterol particle is going to impact or touch or have an event with the arterial wall. That's a more important measure, because you can have big cholesterol particles that impact the wall very few times, and that's okay. So PCSK9 inhibitors lower ApoB much like statins do, but they do it more robustly. They'll do it more stronger. Statins, in the best case scenario, maybe about 50% reduction. For the most part, if you get a PCSK9 inhibitor, you may get 50 to 70% reduction, around that range. So substantially higher reduction in certain populations. And it's also the only thing that we have right now that can lower Lp(a). And it lowers Lp(a) about 20 to 30%. There's some debate about whether Lp(a) can be reduced with other supplemental compounds, but they're not as reliable as a PCSK9 inhibitor. Most common one is Repatha. And so it's a different mechanism completely. What it does is it does not block cholesterol production. So that's what a statin does. A statin works, it affects the liver, and it blocks a specific pathway called the mevalonate pathway, and that enzyme is high up in the pathway, and it blocks production of cholesterol. So it never makes it out of the liver. PCSK9 inhibitors allow that, it doesn't affect that pathway. Cholesterol still gets produced. So it makes it into your bloodstream, and then what happens is it goes around the bloodstream, but it comes back to the liver, and the liver has a receptor that pulls the cholesterol back into the liver once it's done and then gets rid of it. So the receptor often gets broken down. PCSK9 inhibitors maintain that receptor so that you can pull more of that cholesterol out of the blood. And it's happening in the liver, sometimes in the brain. There's some other tissues that have this receptor. I think mostly the liver, but it amplifies the ability to pull the cholesterol out of the liver. Mm-hmm. So the major difference here is that you're still getting production of the cholesterol. It's getting into the bloodstream, and you're also getting production of CoQ10, vitamin D. You're not impacting magnesium. You may not be impacting cholesterol metabolism as much, because at least that cholesterol has a chance to get into the bloodstream and make it to peripheral tissue.
What about the mitochondria? Does it inhibit that?
No, as far as we know, it doesn't impact the mitochondria, and it also has the same, it has similar anti-inflammatory capacity. PCSK9 inhibitors reduce IL-6. They reduce C-reactive protein. Statins do some of that too, but the PCSK9 inhibitors are quite potent in doing that.
So why aren't more doctors using the PCSK9 inhibitors? It's almost like a no-brainer.
Yeah. It's an access issue more than anything else. It costs pennies to make and distribute a pill and a statin that's been around and is generic. PCSK9 inhibitors are not generic. It's an injectable. It's a biologic, meaning it's a immunoglobulin. And so it's got to be refrigerated. And it's injected once every 2 weeks. There are some options now where you can get it a longer term injection, a different type of technology. It's a mRNA technology, and you do it once every 6 months. But it's still costly. That's one of the big things. And so the cost is coming down.
What are we talking about, like ballpark range of how much these cost?
It used to cost about $250 a shot, and that was once every 2 weeks. It's now about half that. So that was a cash price. It's about half that now, which is progress. So you're looking at $250 a month right now. Mm-hmm. So that's still out of the budget for a lot of people, because when you factor in other medications that they're taking, and then anything, and insurance costs, things like that.
Insurance doesn't pay for stuff like that?
Well, that's the other problem with access. The insurance does pay for it, but they really make prior authorization very difficult. You've got to have a diagnosis of peripheral vascular disease, or mostly peripheral vascular disease, or a failure of meeting guidelines with statin therapy. We have to jump through hoops to see that you've failed statin therapy or have a very particular reason why you need this first. And that means having patients, all right, we have to document that you tried 2 statins at high dose, see if you have side effects, and then test the lipid numbers to make sure that you're still above their criteria.
Crazy. Yeah. Like you'd probably have to weigh certain things as well. So if you're on a statin, but yet you're spending money on magnesium, vitamin D, CoQ10, and something maybe to support your mitochondria, because that's going down the tubes. And then you got to deal with your LP little a, because that's not taking care. Like it may just add up to be the same anyways. Who knows?
Yeah, there's that. And it's crazy, because you would think that having the main thing we're trying to prevent here is atherosclerosis of the coronary arteries. Believe it or not, that diagnosis does not get approval for Repatha. The documentation of coronary atherosclerosis doesn't meet a criteria, which is strange, completely bizarre.
When heart disease is the #1 killer of men and women in the world, like you'd think, they'd want to help people out here, reduce costs that eventually are going to be even more expensive. But you talk a lot about the labs as well. And in the past episode, we did talk about labs and diagnostics and scans and stuff. So when you're prescribing, let's say you go for the statin or the PCSK9, then you got to go back and look at the labs again, because we don't feel our hearts getting full of plaque. That's always the problem. We can't go by symptoms. And then we have to test and retest and all this testing. And what I learned from you is that there's the Clearly scan or the Carry Heart scan, like these scans that actually can see the plaque buildup, what kind of plaque and how much percentage blockage. And this is amazing. This is fantastic what we have so far, but you can't go and retest all the time with that. So how are you assessing if something's working or not working with your patients? And that's also kind of cost effective as well.
Yeah, there's a lot of bridging of gaps here. The repeat testing, I don't recommend repeat testing in short time sequences. When atherosclerosis is a slow process, it takes years for change to happen. So even 1 year with aggressive therapy may not really show a lot of change. It really varies per person. To give you an idea of the interval I usually test, if I have somebody that's got really bad disease and they're highly inflamed, I won't test them for a year. I'll have them do aggressive therapy and then test them at a year at the earliest. For somebody that doesn't have aggressive disease, then I'm pushing it out to 2, 3, maybe 5 years, but we've got to maintain therapy. So what am I doing in the meantime? Then there's accessory testing that we can use that doesn't require radiation, may be cheaper, and gives us at least a barometer of what's going on. So in a best case scenario, I'll have a Clearly scan, I'll have a battery of labs to get as a baseline, and then I may even have a carotid intimal medial thickness. So
that's an ultrasound that takes 5 minutes to do. Yeah, not very expensive either, which is good.
Yeah. And then if I'm going to do repeat testing, I want to use the same location if possible, so that we at least eliminate user operator error. But the idea is to get those at baseline, and so I know what that physiology looks like in labs, and then how I can connect it to the imaging. Because then once I start using interventions, I can see what's happening with the biomarkers and see what may be reducing, what's changing, and how those levers are affecting how I can anticipate what I want to change in the actual anatomy I can backtrace it and say, okay, if I say they have a lot of inflammation, then I know what levers to use and what medications will reduce the inflammatory biomarkers. And then that'll be what I track over the years. The carotid intermedial thickness is a nice adjunct because it will give me some vascular health. And usually what's happening in the carotids, the neck arteries, is going to correlate with what's going on in the coronaries. It's not a one-to-one direct connection for everybody, but it can be an indirect association. And so that's something that I can do in the interim. That's something that can be done annually. And I can see if the lining of the artery is getting thicker. So what we're looking for in a carotid intermedial test is thickness and the presence of plaque. And so the presence of plaque is a really strong indicator. And sometimes in some studies, it's a stronger indicator than actually CRP of potential future events. So we can put in really good hands, see if that plaque is reducing, and then also see if the thickness of that lining of the artery is reducing. Reducing is better. If it's really thick, that's problematic. If it's if it's starting to get thin, that's a better sign. So it means less edema, less inflammation, less fibrosis. So that can be used to track in between doing the big scans.
I thought the thickness was sort of genetic. I thought, or is it, you're saying that it can get thicker and thinner. So how does it get thicker and thinner? Because we want more thin than thick in that sense, right?
Yeah, you do. You want a particular range. The intimal media, so it's a collection of a few cell layers thick. It's the endothelium with a little bit of the connective tissue. That connective tissue, when it gets thick, it usually means that it's fibrotic, it's scar tissue. Or when the cell layers get thickened, it means that something is building up in there and it's causing stiffening. Or the artery is itself responding because there's inflammation and it's trying to protect itself. It's getting thicker. So studies show without fail that as the thickness increases, so do cardiovascular events. So this is what was used prior to CTAs that we're using now. It was the test that was used for screening. And it wasn't perfect because of operator error, variations in measurements, because you're talking about like less than a millimeter thick, and it can change significantly if the operator is not really versed in how to do it. It's not a perfect test, but it's a really good test to use in the interim to maybe test if therapies are working without having to do a full CT scan.
So if somebody has a thickness, can you make it thinner, or is it kind of just keeps growing? Oh, okay.
No, you can make it thinner. Yeah.
How?
And this is where with similar therapies that involve controlling ApoB, that control hypertension, controlling inflammatory markers, these same larger concept ideas, they show up in how we can change vascular health in the carotid intima as well. And this is the blood flow in the heart, very similar here. And so that's why the physiology is very similar.
Oh, interesting. So before I met you, I got a CIMT scan, the carotid artery thickness, and I thought that was brilliant. I couldn't believe I didn't know about this before. And the cardiologist looked at it and everything was fine. But she said, do you know what's really good to take for, I guess, your heart health? I can't remember exactly if it was just for the thickness or not, but what she did say was astaxanthin. And I was like, oh, that's interesting. And I knew about it. And she's like, oh, you know. So I was like really surprised that this cardiologist actually even knew what astaxanthin was, which anybody who's been following me more than a minute, I love it for my skin. And it's a very powerful antioxidant. But I don't know if that's something in the list of, I guess, supplements or things that would help your heart.
Sure, it'll help. It's not the first thing I would consider, but it is a powerful antioxidant, anti-inflammatory. It's useful in detoxification protocols too. I think it's a useful supplement. Not the first one I would think of, but certainly something that I wouldn't argue with.
I was surprised. It took me aback. Yeah. Now I want to talk about the things that we can do at home, the diets and the supplements and things like that. We're on this track and get people some practical takeaways. So let's first talk about the diet, because we hear about the heart healthy diet, whatever that may mean, saturated fats, coconut, egg yolks, butter, these kind of things. Should we eliminate them or reduce them, or is there no problem at all? Like, we're really confused. So what's a heart healthy diet that you would recommend if you could design one?
For most people, I tend to recommend a Mediterranean style diet that's higher in protein. And why I like a Mediterranean style diet is because it's going to have the omega-3s, omega-6s and 9s. It's got grains, but complex grains, fibers that are important. It does have vegetables. We do need vegetables. polyphenols for our diet, for our gut health. And then we have to get the right amount of protein. It may not be as vital when we're in our youth and in our middle ages, but as we get older, we have less ability to make muscle protein. And so it takes more to stimulate that. So we need more from our diet. So a Mediterranean diet in that way fits it. It's low in saturated fat. Now, I don't necessarily have a problem with saturated fat because a lot of the studies that looked at it in the past after they've been re-examined, showed that it wasn't even saturated fat that was the problem, it was sugar. The old studies that's how this whole cholesterol theory has gotten really sort of muddled. It started out as saturated fat and cholesterol, and those were poor studies that really tried to prove that. But not knowing what your genetic status is, and in particular, ApoE status, we talked about this before, those people are sensitive to saturated fat. So in particular, in that population, I have them avoid saturated fat. I don't know who's going to be an ApoE carrier. And so as a general rule, I say, okay, let's err on the side of caution and have a Mediterranean diet. If you're a carnivore and you have an ApoE genotype, that's bad. That saturated fat is going to be something your system can't retain, can't manage, and it's going to create oxidative stress. But if you don't have an E genotype, an ApoE4 genotype, then you should be able to manage it, and you could do that. But again, it comes down to being tested.
Yeah, bioindividuality rules. Like
yes.
When we hear this studies coming out, or somebody wrote a new book, or you got to take this with a grain of salt. We don't know if it's going to work with you or not, because you may have a certain genotype that just completely gets ruined because of whatever it is that's been recommended. And that's why we get guidance from a professional.
Yeah. Other things. Well, let me add a few other things though about diet. So it depends on your goals too. And this is where fasting comes in. I have a lot of high performing athletes, and so they ask me if I think you should fast. And usually the answer is no, because it doesn't meet their fitness goals. But I think everybody can benefit from a periodic 3-day fast.
What does that mean, periodic? Like once a month?
Like monthly. Yeah, once a month, 3 days, water, or you could potentially use bone broth, but keep it low calorie, very low calorie, basically fasted. And I think that also helps to maintain some autophagy, some cell cleaning, helps to give you a little bit of resetting. I think about that also from an evolutionary standpoint. I mean, this is how we were in ancient times. In ancient evolutionary times, we had a feast. We killed something, we had a harvest, and we ate it, and then we didn't eat for a little while because it wasn't there anymore. We didn't have refrigeration, we didn't have preservation mechanisms, and so that's how our physiology evolved for hundreds of thousands of years. Mm-hmm. So I think that trying to get something, at least hearkening back to that, is helpful.
Do you know Dr. Walter Longo?
I know of his work. I don't know him.
Yeah. So when I was doing my gerontology studies, he was my professor, and he's famous for the fasting mimicking diet.
Sure.
And of course, pulling out all this research and the benefits. So he would completely agree with you in terms of longevity, because actually you're working at a longevity clinic as well. So you're thinking about the future self. So if anybody doesn't know what the fasting mimicking diet, let me explain generally. It's a 5-day quote unquote fast, but with food. So he's created these soups and a bar, some supplements and stuff to get you through this 5-day period, because it's not so easy to fast if you've never done this before too. Yeah. And especially his goal was really working with people who have serious diseases, not just the everyday person, although it's the everyday person who's also winding up buying these packages of quote unquote food. But it was because he's such a proponent of fasting and the benefits of fasting, but he could never convince a doctor who's got a cancer patient to not feed them for 5 days.
Yeah.
So this was his solution. So I'm wondering, and when you say this periodic 3-day fast, would a fasting mimicking diet with a little bit of food have the same benefits?
I think so. Yeah, based on his research, it's not necessarily the food, but the composition of the food and the caloric intake. And so the idea with that diet is to still be able to maintain some caloric intake, relieve some of the hunger pangs by having a very well curated meal with the right macros too. Because it's not like you're having, the caloric intake is low, and it's like 500 calories. Mm-hmm. It starts at 700 and it goes to like 500 after that. Mm-hmm. It's not saying that if you have 500 calories of chips or ice cream, it's going to have the same effect. No, it's got to be the specific composition of ingredients, and that's what he's curated there.
Yeah. Okay. And also, you don't need to buy this package. I mean, if you do, great. But you can go on to build your own. You can make it with
That's
your own
right.
food. Just make sure you get the right macros. But that being said, I know a lot of people just go, it's easier just to buy the box and it's there and I don't have to think about it.
And that's why you can just do a water fast or a little bit of bone broth, and that will do it too. I think keeping the caloric minimum, but just enough you got to maintain hydration and electrolytes too. So that's why that's helpful.
And also not exercising, because I think the worst combination, and he even said this as well, is like, exercise and fasting don't go together. And like you said, there's the athletes who need their calories and maybe shouldn't be doing this. But is there a workaround for those athletes? Like if they were like, oh, I also want longevity and I want it all. Do they do a shorter fast or no, not at all? What would you tell those people?
Yeah, we'll tell them, and as athletes, it's part of their mental well-being. So telling somebody to not exercise for 3 days or more, if you're doing the mimicking diet, that's a really hard sell because that's a daily routine for them. So I'll tell them to exercise 1 or 2 days at the most, but do not do it on the last day. If they can take a break for 2 days, great, maybe exercise 1 day. But the further into the diet, the more stress they impose on their system, the harder, the worse. It helps, but because exercise in a fasted state also can improve it can improve the fat oxidation. That's the idea too. We're switching into a fat oxidation metabolism. So it helps to do that, but it's just really challenging on the body and then hunger and then in the whole system too. So it's not something I recommend unless they do it, not all 3 days.
Yeah. Okay, so let's jump into supplements because there's things that we can do. Maybe we don't need to go as far as a statin and to control our lipids, but there are a couple of them that I have recently, well, not recently, but that are popping up more or less. And it's red yeast rice, psyllium husk, and nattokinase. And let's start with those and your thoughts and if you use them or not, and then maybe some of the other basics that we all should have anyways.
Yeah. So let's start with red yeast rice. Red yeast rice got a lot of popularity and really made a mark back when statins first came out because it was the source material for some of the original statins. It's chemically identical to lovastatin. And so instead of having to get a prescription for it, people wanted to go out and get it as a supplement, and it was marketed that way. And originally, it did have good outcomes, up to 35% reduction in cholesterol. I think it was actually in LDLs. But the problem was that after a few years and many manufacturers claiming that this was red yeast rice and actually maybe it was just something else that had a little bit of lovastatin mixed in with it, so it still was potentially giving the same thing, but it was being marketed the wrong way. Anyway, it was a crazy market. FDA decided to clamp down and reduce the main active ingredient that was in red yeast rice, and that's called monocolin A. And so now there's very little of that active ingredient in most of the available red yeast rice in the United States.
Yeah, I heard about that.
Yeah, potentially it may be more available in the
Hong
supplements
Kong.
made in other. Yeah,
that's where I got mine in the beginning. They had the active ingredient and it worked, but I'm not sure about it.
Yeah, and so it's very variable. We don't know where it's being made, how effective it really is. And you've got to take a lot of it now. That's what people also don't realize. You're looking at 3,600 milligrams, 24 to 3,600 milligrams, which is a lot of pills for a possible benefit. We don't even know. So I often recommend, there's some other newer agents that have found to also have similar activity, but better in the sense that they may not lower the cholesterol as much as the original red yeast rice, but they have other systemic benefits because they're polyphenols. They have other anti-inflammatory, antioxidant benefits. So one of those is bergamot. Bergamot is a citrus peel extract, anywhere from 800 or 400 to 1,000 milligrams, depending on the pill availability. And that inhibits a similar enzyme. It inhibits the HMG coenzyme A reductase enzyme that statins also inhibit in red yeast rice, but it also has other benefits because of all of its polyphenols. It's a polymethoxyflavonoid or something. There's another one that's out there. They're a combination tangerine and nobelatin, similarly from orange peels, different species, but they also have wider benefits. That you got to take with a meal, and sometimes it may not be as effective in lowering the LDLs themselves unless you go at higher doses, but it has a lot of other fringe benefits. It can help reset the circadian rhythms. It actually helps with collagen, so it may be useful for skin. So a lot of other fringe benefits with that one. And then what else is? I think those are the two main ones that I use. I'll use aged garlic extract as an anti-inflammatory medication specifically. It won't impact the cholesterol as much, but it's good for plaque, the PLAC test, to reduce that enzyme and then oxidize the LDL.
What about the plant sterols? Like these, just to give people I'm not sure what they're called in the US, but they look like little Actimels or these, there's a name for them. It's like a little yogurt type drink that I don't know what's it called in the US.
There's a couple of them. I mean, there's a plant steroid drink that I know called Dosed, and then I'm not sure if it doesn't sound like it's the same one you're thinking of.
It's just a little drink, but they also sell supplements, pills or whatever.
Yeah.
In the end, these are all plant sterols. What are your thoughts on that
I think those are useful as well, but you end up having to it depends on the dose again. Vitamin E is potentially useful too. The tocotrienols are the ones that are more lipid centric or more effective in lipids. So there are some ways you can take that tocotrienol, isolate a little bit more concentrated, and that'll help.
What's the tocotrienol? Tocotrienol?
Yeah, those are basically specific isolates, subfractions of vitamin E.
Okay. So would that be in a general vitamin E supplement or
not? It will be, but you have to look at the breakdown because there's tocopherols and tocotrienols. And so some of those have more of an effect on cholesterol than the others. So their ratio varies per supplement.
Okay. Interesting. Okay. So then one thing about the red yeast rice that you said it works like a statin, but does it also have is it a mitochondrial inhibitor? Does it affect the CoQ10 and the vitamin D and the magnesium the same way, or?
It will, because it's acting on the same enzyme. It's just not as potent as a statin.
Okay.
So there will be, if you take enough of it, you may get muscle aches or pains, but then you've got to take a lot of, if you're prone to that. Not everybody gets myalgias with statins, but you may get some of the other deficiencies if you take enough of it.
Yeah. One thing that did actually work for me, but I wasn't understanding the mechanism of action or what was happening, because I was getting this from Hong Kong. Because in the US, obviously it's not, the active ingredient is taken away. Yeah. But at the same time, I've interviewed somebody before about the red yeast rice, and he said it was also because because it's a quote unquote natural or plant, like in a supplement, it's not regulated. So he's like, but I don't know how much the patient's actually getting in the end. That's right. And we just stay away from those.
All right. And then you mentioned nattokinase and
psyllium husk.
Yeah. Psyllium husk is also, that's an easy one. That's why fiber has also been talked about as good as heart healthy. There's a lot of reasons. Psyllium husk is a non-digestible fiber. So what it does, it's partially non-digestible. There is some that's digestible, but it helps your gut microbiome, and it also absorbs some of the fat. So you're doing two things here. You're not absorbing as much of the fat that might be in your diet, and then you're providing a prebiotic. So it's something that helps feed the microbes in your gut the right way, helps improve gut health. That reduces inflammation, that has a direct impact on cardiovascular health.
But when you take that, you got to drink a lot of water.
Yes.
It plumps up, it gets gelled like a flaxseed or chia seed. And then you're almost chewing this as you're trying to get it down. And I think the warning is, don't take just a little bit. You got to drink a lot of water, because otherwise you're just constipated or reverse. I don't know. But I followed instructions. So everything was good for me. But well, it's also great if you do that, and it's a filler too. So as it expands, it'll expand space in your stomach and reduce appetite too. And that way it can help with weight reduction and secondarily give you some cardiovascular benefits that way too. One thing I'm thinking, because my husband cleans the cups after I drink this, and he's like, what in the world is this? It's stuck. It dries and then you can't get it off. I explained it to him. I'm taking this for my heart health. And he goes, but is it doing the same thing inside your body, like stuck? and it makes me question, is it, what's happening inside the gut if it's sticking to my cup like that? Yeah. Well, it might be that just it's getting rehydrated. It could be that's where it's sticking, where it needs that fluid, like you were talking about. Ideally, if it's sticking to the side, it's a fiber. It's going to be eaten by the gut microbes. So hopefully, you're pooping it out just like everything else. I always imagine it. It must be sticking to the fats or the cholesterol, whatever. It's pulling it out because it's sticking. That's right. I don't know what it is, but that's one of my protocols. And what about the natto? Yeah, go ahead.
Yeah, nattokinase.
Yeah.
Yeah, nattokinase is the natto. It's the fermented natto. Basically, it's the growth that happens on fermented natto and or soy type
Soybeans.
of
Yeah.
product. Yeah, and it is an anticoagulant. And so what nattokinase does is it helps to recycle heparin, which is our natural anticoagulant. And this is really interesting because it resides in the glycocalyx, that lining that's around the endothelium. That last lining that protects the endothelium, that like slimy layer, that's the protective coating that keeps things from sticking to our blood vessels. So there's a lot of stuff that resides in there. There's proteins, there's enzymes, and it also covers up the molecules that grab to the immune cells. So in that layer are also these anticoagulant molecules called heparin, and nattokinase helps our body regulate when those get released and when those get held onto. So if you have a blood clot, or we make blood clots that are microscopic all the time and then dissolve them. And so heparin is part of the molecule that dissolves those. And by taking nattokinase, we optimize the protein in the glycocalyx, maybe help its health and maintain a little bit of amplifying that ability to prevent clots from forming. So when you think about, so there's many cardiologists believe, and they have a theory that part of the atherosclerotic process involves microscopic blood clots that aren't being controlled. And this is one of the theories of Lp(a). Lp(a) is not only a inflammatory compound, but it's a thrombotic compound. It prevents clot breakdown. So nattokinase theoretically can help that because it helps the body continue with the clot breakdown when it should.
I understand you need to take, I think, 10,000 FUs per day.
Yeah, right.
Because I think the capsules are, I don't know, I think they're much lower dosage. So I think people who are doing this are not quite taking enough, because there's some research study that shows that's what was the effective dose, but maybe everybody's different. So yeah, is that what if somebody wants to get on nattokinase,
yes,
that's something to look at, right?
That's right. 10,800 was the exact dose. They're fibrinolytic units. When you say FUs, so you gotta qualify that.
10,000 FUs, yeah. So, okay, this is a supplement I think it's not difficult to get. I'm wondering how it would compare to natto. Because if I'm in Asia, I see natto on the menu or somewhere, I'm getting it. It's not something I can get all the time in Europe, but I wonder how it would compare to an actual natto, or is it just like, that's why we have a supplement because you can't get enough? I don't know.
Well, it's not the actual natto. It's the fermented growth that comes on the natto. So getting natto itself won't necessarily do it. There's another compound that's similar. It's called lumbrokinase, and that's actually from like earthworms, and it's got a higher fibrinolytic potency to it. But again, there's often the case with supplements, there's quality control. Are you getting raw bulk or are you getting concentrated forms? So it's harder to know what you're getting with lumbrokinase, and it's more focused to just fibrinolytic or clot breakdown. Nattokinase has a little bit of a wider function to it.
Interesting. Yeah. So let's talk maybe about some of the common ones that most people are taking for their heart health, like aspirin or fish oil.
Yeah.
So, is that any beneficial, and how much do people need to take?
I'm a big supporter of using aspirin as long as you don't have bleeding or bruising issues. In the elderly, it's something to be aware of. The bleeding complications are there. They're documented in many studies, and so we have to be a little careful as we get older using aspirin. But I do like it for its ability to inhibit clotting and as an anti-inflammatory. Aspirin,
So should people test something before they start taking aspirin, or do you think it's kind of everybody should be on this kind of a thing?
I think you could probably get away without doing a test. I mean, the test ends up being some sort of genetic-based testing, and there's not any one gene. It's more of a collection of SNPs. I think it's more about looking at risk factors. Do you have, and how you respond too, because some people, it's very clear once we start aspirin, they bruise very easily, or they don't have, or even before I've started it, they have very fragile skin and they bruise. I'm going to be cautious about using it on them. So we can probably tell clinically, but it's, in the right population, I think is very useful. It's also one of those things, aspirin, and you bring up fish oil, when you take the two of them combined, it helps our system make some really highly anti-inflammatory compounds. They're both anti-inflammatory on their own, but when used together, they amplify our ability to make what are called pro-resolving mediators. Mm-hmm. And these are higher potency anti-inflammatory compounds. Those are sold as a specific supplement. But and you could take those, and you could also potentially just take a good fish oil and then a baby aspirin. And you don't even have to take baby aspirin every day. You could do it every other day or something like that. Because remember, the lifespan is long. It will stay in your system for a little longer than a day or two.
Do you have different patients with different profiles, and you'd give more or less dosages of aspirin?
Yeah, I do. And it depends on if they're on other anticoagulants, if they're taking something like nattokinase, what are their other health conditions, if they have a propensity for bleeding. I'll try and find a way to get it involved into their treatment. But if there's too much of an issue, then I won't.
Okay, so that's a warning. Don't just pick up aspirin and start taking it. Like, go ask your doctor, and all these supplements as well. This is not for everybody to do. Just, again, check with your doctor. And you mentioned the pro-resolving mediators, and I think they're also called SPMs as well. And these are supplements that people generally buy. And you're saying, well, let's just get a good fish oil and an aspirin, and you may have
that's right.
benefits, right?
Yeah, that's right, because they are derived from omega-3s, and omega-3s on their own have a really good anti-inflammatory capacity. Very helpful in so many ways. So they help with balancing the omega-6s, because we have so much of that in the American diet for sure. So we need to balance that, even if they're coming from healthy sources. Most of the omega-6s come from processed foods, seed oils, and those are highly inflammatory. But even if you're getting them from natural sources like nuts and meats, if you're still getting an overload, you're going to make more, it's going to convert into compounds that may be inflammatory. So we still want to balance that with omega-3s. And so when you get those balanced, omega-3s will inhibit the omega-6s from becoming problematic, but they are themselves anti-inflammatory. So they'll help the system in that way. And they also are important for membrane health. So I'm a big supporter of omega-3s also.
Cool. Okay. Now I want to move on to blood flow restriction. And I think you're familiar with this, right?
Yeah, a little bit.
You're in that space,
Yeah.
in this sort of biohacking space, because I meet so many people who don't know what it is. I think it's quite amazing. But before I move on to that, is there anything else about supplementation that we should know, or you'd recommend, or stay away from, or diets, or anything, things that we can do at home?
I think that there's probably a place for most diets. It's just a matter of cycling them. I don't think any one thing is what we should be doing forever. It's important variety is important, and different ways to test our system. And also when it comes to supplements, when you're looking at proprietary blends, it's important to see what's in the formulation, because it may just have a tiny bit of an active ingredient, or it may be something that you're already taking somewhere else. A lot of times they're just glorified multivitamins with a sprinkle of something else, and they're calling it something that's heart healthy. So it really just means if you're going to step into this field and this way of treating your health, get a little granular and look at what you're taking. Don't just trust the claims.
Good advice. Okay, so the blood flow restriction, if anyone's been following me more than a minute, they know that I love these things. These are bands that you put on your arms or your legs. And I originally found them because I was amazed with how they can help preserve muscle mass, especially if you're going through surgery. Yeah. And surprised more people aren't talking about it. And when I first learned about them, I understood that they came to being because of cardiac rehab patients in Japan in the 1960s. So it's nothing new. But I'm wondering if you've ever looked on the benefits of BFR or blood flow restriction for heart health, either in research or in your clinical practice, and what are you concluding from that?
Well, I don't have much experience. I've recommended it to some of my patients. There's not a large percentage of patients that are using them, but they run into two different categories. One are fitness enthusiasts that want to find other ways to just amplify their workouts or get more out of their workouts, even on a rest day, or they'll take particular days to go through a workout with the blood flow restriction bands, and they love it. And then there's the patients that are immobile, that for whatever reason, maybe fatigue or because of mechanical injuries, then I'll recommend a blood flow restriction band. Not everybody takes me up on it. It's usually patients, they'll say, all right, I'll just start to try a walk, and they don't really conceptualize how beneficial these can be, because you don't even if you're just going to go do some basic exercises with a blood flow restriction band, it really amplifies what you're doing there. I think part of the challenge is they're not cheap either. Getting a good blood flow restriction band is going to cost a few $100s. And so it's
Best.
it's not, yeah. And so there's the buy-in cost as well.
Yeah, I've interviewed others on this. We often talk about the benefits of muscle, and this is an issue for when we're going through menopause. It's harder to build muscle. And I had my own experiment just with my hip surgeries, and I was so devastated that I'm going to lose my muscle. I worked so hard for this, and I've been using them, and I've been able to maintain it and actually even grow it with very minimal movement, just my rehab exercises, which just blew my mind. But I've been talking about this for years and years now, so I get good feedback. So I think it's particularly interesting for physiotherapists to look at, especially if their patient is immobile. And as a gerontologist, I'm also wondering, why aren't we talking about this for older adults who will not lift heavy or cannot, or they're more restricted? But also, we like it for this muscle, and it's very well known for that. But originally, you go back, it's supposed to help with the blood flow. It helps with the strength of the blood vessels. It's supposed to do all these magical things with the heart that maybe we're not paying enough attention to even with the brain and their skin, right? Because you get more blood flow, and this is all fantastic. But I would like to hear from a perspective of somebody who's not selling these bands, because when you interview somebody who's selling the bands, it's just, wow, okay, it's a miracle. But I really wonder, and then there is research out there showing the benefits. And just so people understand, there's some bands, when you put a band on, it kind of hurts. It's like there's restrictive, and you're not supposed to do it too much. It has to be a certain pressure, and you don't do this more than like 10 minutes max. And so then you get quite amazing benefits even with 10 minutes. But there's other bands out there that inflate for 30 seconds, deflate for 5 seconds, are much more gentle. And for me, when it's somebody who has maybe have heart issues, I feel more safe recommending something like that. It's less restrictive. But at the same time, always talk to your doctor or run this by, or because it could do some more damage than good. But I am curious to hear more perspective on how really beneficial it is for the heart, that from someone who's just a little bit more unbiased.
Yeah. The use of the blood flow restriction bands is going to amplify nitric oxide. We know that. It's going to consume the nitric oxide, and then the return of blood flow sort of amplifies the reproduction of it. That by itself is a profound anti-inflammatory effect, as well as a vascular dilating effect. When you look at, there's a device that was used for a long time. It's called electrocorporeal counterpulsation. And in heart failure patients, it was a device that was attached to blood pressure cuffs attached to arms and legs, and they would squeeze on and off in pulsation timed with the heartbeats. And therapies, they would do 20-minute therapies, things like that. And the idea was not only that it was specific for heart failure patients, and it would be able to train the heart to be able to function better with the output that it has, and either improve blood flow to the periphery by pulsating it at a different time frame with the heart cycle. So when you look at blood flow restriction, I think it follows a similar concept. Although it's not being timed with the heartbeat itself, it's putting a little bit of stress on the myocardium, but enough so that it can start to work better and improve a little bit of delivery, oxygen delivery, and the cardiac output. When you're doing it to either both legs, both arms, one leg, one arm. It depends how extensive it is, but I think in that way, it's something the heart can push against, and then it inflates during the push, when the heart squeezes, and deflates when the heart is squeezing, and inflates when the heart is not. So what that does is it helps return some blood flow back, and it doesn't push against the resistance of the heart. So it helps to get a little more flow peripherally. That may be part of how, and in that way, it strengthens the heart muscle and allows it to develop a little more.
Interesting. I never heard of that. What was that called? Pulsation?
Yeah, counterpulsation.
Electric counterpulsation.
Yeah, not electric, EECP, extracorporeal counterpulsation.
Oh, EECP. Oh, wow. Interesting. Is this something that you have to get in a clinic, or people buy devices and do it at home?
Yeah, you would have to get it in a clinic. Yeah, in a clinic. It's not available because it's a bed. I mean, you can imagine that it's something that have people put their arms and legs into, and it was popular when I was in training 20 plus years ago. I don't see it much now. But the theory, I think, is related. Yeah,
definitely. Super interesting. Okay, I could talk to you all day long, but I have to wrap up here. We've gone way over time. So if someone's listening now and they're feeling a little overwhelmed, what are 3 things that they should actually do starting today to improve their heart health?
First thing is take a walk. If you're fit, then make sure you're getting enough zone 2, some low intensity aerobic activity. I think that there's a push and a discussion about trying to get high intensity workouts all the time, and we forget that we need to do some low intensity, just steady state aerobic activity. And if you're not doing any fitness, you got to take a walk. Start doing something. Fitness is our number one lever to improve our health in every way, in every system. Number 2 is optimize your sleep. Make sure you're getting the right amount of sleep. Not only is it important for stress management, but it's important for cortisol, for blood sugar, for mental health. It affects everything. So nothing new here, but we have to hammer the basics. Number 3, if your diet is off, just get your diet controlled. Look at what you're eating. Make sure we eliminate inflammatory foods. Try and get enough whole foods in your diet. And maybe if you're feeling like you have a challenge with weight, you don't have to go to pharmacologic tools. I mean, you can just start by looking at what you're eating and eliminating one small thing a day. And then just do that. You don't have to be perfect. You just got to do one thing at a time, one small thing, and just do it regularly, and then add another small thing regularly.
Excellent. Great tips. Walk, prioritize your sleep, and dial in the nutrition.
Yeah,
These are the big,
nothing sexy.
Yeah, they're big levers though. We all want the supplement, just hack our way out. But this is the hack, is just getting down to the basics. And I appreciate so much what you're doing, and you're taking heart health beyond the norm. And this is why I love to speak with you. You're really on the ball and thinking differently outside of the box. And if anybody wants to work with you, they can find you at Boulder Longevity. I'll have the link to that in the show notes, or you can also find you on Instagram as well, Dr._Abid Husain. And I'll have links to that. Is there anything else, any other place you'd like to direct people if they want to find you or ask you more questions? Where should they go?
Yeah, you hit them, the office at the Boulder Longevity Institute. I've got my Instagram page, and then I have a YouTube page where I put out some longer form content, and that is spelled out Dr. Abid Husain.
Great. I got a link to that as well. And also, you mentioned the last time I spoke to you, you've got some upcoming vascular medicine and cardiology health course for practitioners. Is that still running?
It is, yes. It's basically completed. We're in the final phases of it. It'll be on a platform called Next Generation Health, and it's a cardiology and vascular biology course.
Cool.
So it's focusing on atherosclerosis, and then at some point we'll expand it to AFib, hypertension, and things like that.
Oh, wonderful. Well, thank you so much for everything. And I appreciate your time, and I appreciate everybody else's time who's got here to the end. You're obviously just as interested as I am in heart health. And there are so many things we can do, and you're really taking it to next level. You're not just thinking like everybody else. So thank you. And I just hope that you have a wonderful day and a good night, good morning, anyone who's listening, and I will see you next time.